the final session of the day, and it's really an opportunity for us to have, I suppose, a conversation, a discussion with our panel of experts about what we see as being the future, the way forward for M-Health research. We've heard loads of fantastic developments here today, wonderful research projects. We have a room at the moment occupied by people who are clinicians, scientists, engineers, and also health technologists, academics. I think it's a great opportunity for us to think about how we can collaborate together. So I think from some of these conversations come great ideas and subsequent discussions and conversations. And someone's turned the lights up.
No, sorry. Trying to
get intimate. So I'd like to maybe open the discussion and be very happy if people would participate in the conversation discussion. I don't want to sort of hog the stage as such, but I did want to ask Jane if she would open the discussion and have a conversation with our panel of experts, and then leave it open to the room to partake.
Okay, so yeah, I don't need to go here, but this is fun, having a microphone. So thank you very much to our speakers today, very much appreciated. I suppose one of the questions we might ask, in terms of health improvement, what would you see as the next obvious opportunities for M-Health research?
Put someone on the spot. Jeremy, would you mind taking the first question?
The next opportunity, I'm not sure that we've really built on and realised the existing opportunities, and I guess that we've heard of some successes, but as I pointed out in that recent systematic review, there is unexpected heterogeneity in the results of these studies. I think just understanding the principles that we can make more reliable interventions. And what I didn't mention in my talk, the thrust of the talk that I gave in London in February, was actually about trying to uncover the generic design principles that we need to understand much better, and which then can be used in whatever intervention we're developing. So generic principles like how to give feedback to people so that they can understand it and act on it. And there's a lot of studies that need to be done on that. We've done one or two small studies ourselves and come up with some interesting results. If you give feedback about people's individual performance, they don't seem to respond as well as if you give feedback about their performance as a team or as a group. But there's another published study which shows that if you give feedback about individual members of the group, what you can end up is regression to the performance of the lowest performer. So there are some real subtleties in how you give feedback to individuals. So we need to do more scientific work around, if you like, theories. These are a bit like behaviour change theories, but they're different. They're very specific theories. But once we establish those, and it's a bit like the theories of what engineers use to build bridges. They have strong theories. They have principles that they can use to produce reliable bridges that don't fall down very rarely. So I feel that what we need to do is to put a lot of effort into that more scientific theory testing.
And just taking up that point, I mean, the corollary with bridges, I think, is very applicable, because a bridge has to stand up in all sorts of weather. And I think even the work we were doing, Jane, has revealed the incredible individuality in terms of how people interact with technology. So as well as those very strong principles, I think you need to have an incredible amount of flexibility built in, which will allow people to personalise and thereby hopefully increase their motivation and interaction with whatever the intervention might be.
But there are some basic principles, for example, of human perception. There's a discipline called information design, which is all about how to help people find information reliably, fast, and interpret it without error. And that applies to humans, full stop. There's a very evidence-based theory, there's work going back over 30 years led by people like Pat Wright from Cambridge Applied Psychology Unit, which often you see ignored by the developers of M-Health interventions. And I think that's one of the problems, that too many of these projects are led by technologists rather than by people who understand about humans. Ultimately, it's people using the technology. You can make the technology as fancy as you can, but if it doesn't display a risk in a format that humans can understand, you're in trouble.
Yeah, I think, to be honest, we're only really scraping the tip of the iceberg as regards e-health and where it's going to go over the next number of years. And if you look at what is in store over the next, say, 3 to 4 years from a European programmes perspective, you know, there's lots of money going into future networks, future internet, big data, smart cyber physical systems, Internet of Things. And I mean, all these are going to be generic technology enablers for the whole e-health area. And, you know, we're seeing more and more that the Commission now are trying to capture the full value chain of potential actors within this space. So, you know, they don't just want to see technology providers in projects anymore. You know, they want to see the technology providers plus the end users going in there and collaborating and having that end user perspective being put in at a design stage. If we look at something like, you know, e-health records, something that there's been a lot of talk about. I mean, the future with health records, e-health records, is you want to be able to access your records at any time, on any device, on any network, anywhere in the world in a safe and secure way. And, you know, it might sound that something like that should be relatively easy to do, but we're a hell of a long way away from it. You know, and the work that's going to be done over the next couple of years in big data, in 5G networks, will all enable that.
Ask you to use the mic, if that's okay. It's on.
Thank you. So my question's really about whether or not we should be considering M-Health and M-Healthcare under the same umbrella. And the reason I ask is because whilst there's significant overlap, the initial interaction with the mobile component may differ. So M-Health, if we think about that in regards to people actively going and choosing to engage through an app store to download something about physical functioning, M-Healthcare related to being put into or being recommended a certain piece of technology via a healthcare system, or being referred to a certain kind of technology. And I actually think that initial interaction is very different and very important to understand. So my question is whether or not we should be thinking about these two in terms of the methodology and the approach slightly differently, or whether there's sufficient overlap that we can consider them both under a single umbrella.
Happy to jump in on that, if nobody else does. I think you're absolutely right, and I think that by talking about e-health and m-health and health informatics and electronic health records, we tend to miss the point that all of this stuff is around healthcare, brackets E, brackets M, brackets online, whatever, and that what we should be talking about is perhaps digital healthcare, and new pathways of care, new models of care supported by technology. And I think if you shift the vocabulary in that direction, then instantly the focus becomes much clearer. It's around what are the problems that we have, for example, scalability of behaviour change interventions, and what's the potential role of technology to help that, and that it instantly suggests different evaluation questions from if you focus instead on the technology and say, well, are the apps accurate? Maybe that's not really the question, and an answer to that question doesn't really help you move very much further towards establishing new care pathways or empowering people to self-manage, which is ultimately a lot of what this is about. So yes, I think you're absolutely right in shifting the context away from the technology and out towards what we're actually trying to achieve, which is to help people stay at home for longer despite long-term conditions and avoid damaging acute episodes that are expensive, extremely anxiety-provoking for both the person themselves and their friends and family. people with COPD going into hospital at 3 o'clock in the morning, getting arterial punctures and so on, near-death experiences, extremely unpleasant. And as a result, many people with COPD would just rather say no to all that. So that's the real challenge I think we've got, is prolonging people's healthy lives at home for as long as possible, supported by technology where applicable. But it may actually be social networks that are actually a key part of that. And again, the social media are just the very thin skin on a new way of opening up connections with other people in the world.
So the Smart Move study, for example, that you presented this morning had patients who self-initiated, patients who were referred. Sorry. So the Smart Move study had patients who chose to engage and enroll, and patients who were referred to enroll. Do you have any data on the differential outcomes, quantitative outcomes, with regards to those two subpopulations? I know the numbers are small, but it'd be interesting to see, for example, whether people who were sufficiently motivated to say, I fancy a bit of that, versus my doctor told me to do this, I better do as I'm told, and we know issues around adherence to that. I'd be very interested to know whether the push from the doc is making any difference with engagement and ultimately outcomes.
I mean, you're right. I mean, the numbers were small, so it's hard to conclude from the study. However, it was included in the statistical model in terms of the referral pathway. It didn't come out as any significant quantitative difference. But I think it's an element of it. I think also what was striking was the I've referred to it before, and I think you're right. I think in many ways the social media element or the interactive element with the technology is an enabler to a wider social connectedness that creates resilience and creates a sense of belonging and a group mentality and a peer group. So I don't think we should forget as well, as much as we're talking about technology, that there's huge value in the face-to-face stuff, and I don't think anybody's denying that. But the beauty of the technology is that it seems to really be a very strong enabler of that, in terms of finding those like-minded individuals who you can connect with and then can act powerfully in terms of supporting you through a behaviour change process.
Just to respond, in text messaging studies, there's a systematic review, I think, of sexual health promotion in adolescents and young people, which shows that is an effect modifier. I think it's not a big effect modifier, but it's significant. Whether you were referred into the text messaging program or whether you saw an advert or something else and signed up for it yourself does make a difference. It's more effective if you signed up for it yourself.
Thank you.
Sherry, was that a feature of your study, the Twitter study?
Do you mean patient referral?
Yeah, in terms of whether you recruit people in or whether people come along and voluntarily sign up.
It was primarily volunteers in our study, so I wouldn't be able to kind of look at whether there were differences between referrals, but that's an interesting question. To your original question about mHealth and mHealth Care, my thought about that is that in order for it to have real impact, mHealth and digital health, it's going to need to move into the healthcare system. As long as it's outside of that, for lack of a better term, it has a novelty feel to it. And the only way for it to move into the healthcare system is for evidence to happen. So we need that process. Gathering evidence is a slower process than developing technology. So we have those two speeds, which people have already alluded to today. But you can develop an app tonight, but you can't run an RCT tonight. If anyone here's running an RCT, it takes a very long period of time, so we have different paces. But it's so new right now, and there's so many innovations, and the process of research is going to take some time. But I feel like the real impacts will happen when it does become more integrated into the healthcare system, where primary care doctors are referring apps and very engaged in the process of the patient using the app, instead of it just being, consumer directed. And because we see that apps, the average app is only being used for like a few days and that kind of thing, so we don't have great engagement in most of them. So it'll be interesting to see how that process happens, and I'm sure it will be facilitated by evidence.
Hi, just on that point, Sherry, sorry, Maria Quinlan, my name is from the Applied Research for Connected Health Centre in UCD. Just on that point, I think what struck me most about your talk, and all the thoughts were so interesting, so I just want to say that first, but what struck me about your talk was that even with the evidence, those good behaviour change interventions for, say, diabetes are getting traction. And that's something that we're trying to look at as a sustainable adoption of implementable solutions.
Right.
And in work that we've done on the HSC, and I'd be interested to hear the thoughts from the panel, you know, it's a system where public health nurses have only gotten mobile phones in the last couple of years. There's not the basics in terms of technology for some healthcare workers. Employee engagement in a recent study that was published by the HSE, it's really on the floor in terms of morale, and trying to interface into a system that has so many complex issues in terms of the adaptive capacity to change. You know, it's an area that we're trying to understand and work with the HSE to try to understand that. But I just wanted to ask, in particular in relation to your own, you know, have you abandoned that route of getting into the healthcare system for the consumer route, or is that something that you're still interested in, changing reimbursement patterns and things like that?
In terms of the traditional intervention or the social media delivered intervention?
Well, in terms of the interventions that you spoke of for the diabetes.
Yeah. And those are traditionally delivered, and we haven't totally abandoned getting that to be part of the healthcare system, but the big challenge is it's just not a really feasible model because it's so intensive and expensive, and I feel like the opportunity with technology is to make that more feasible. I mean, you don't have to come in and talk to me for an hour a week for me to help you with your weight. You know, that requires transportation and scheduling and all these different things. So we have effective strategies, and I think the modality by which we're delivering them is just really infeasible. And so there has been a little bit of movement towards that. The YMCA in the U.S. has adopted the diabetes prevention program and provides it in many of their facilities throughout the country, and so that's been one dissemination success. Primary care physicians are now getting reimbursed to do behavioral weight loss counseling. The challenge of that is that I think it's difficult for them to do that in the limited time that they have and all of the things they need to cover in that limited time, although they can have somebody else in the clinic do the counseling and still bill for it. But the barrier to that is that they don't necessarily have the training for that, so they can get billed for something and that they don't know how to do that counseling. So there's that disconnect. So there is some effort to move those more traditional ways to be reimbursable and to get into the healthcare system and available to more patients. But I think if we come up with different modalities by which to bring these behavioral strategies to patients that are cheaper, then maybe we won't have, we can circumvent those barriers, but we would need evidence that they work in those modalities, like through a mobile app or through a social network, and then dealing with the privacy issues, and then how to communicate via those mediums. One thing that we've learned in our work is that it's just different the way that you communicate and the way that you deliver information and the way that you counsel, and every time we ask a question it leads to about 100 more to figure out like what's the best way to do that. So but I think it's a worthwhile avenue to figure out for all behavioral counseling, whether it's tobacco, obesity, diabetes management, or whatever topic.
Just to take up that point, I mean, we have a really, I suppose, interesting context here in this country where you have, you have primary care or family physicians, which, they do manage, according to the stats, 90% of healthcare contacts, but we have a system in primary care where almost universally paperless, highly efficient, flexible, sort of very adaptable, because it's sort of run on the basis of a small business, interacting with a secondary care sector which is still entirely paper-based nearly, and so you have that struggle of those two very different systems trying to interact with one another. But despite the sort of the potential barriers of that and the gloom of that, I mean, I think there is there's a new sense within the HSE and the Department of Health around the importance of primary prevention. And one of the biggest problems in this country is there's absolutely no incentivisation in primary care for primary prevention in the Republic of Ireland. We have a 40-year-old contract it's entirely a sickness service. But with the new under sixes contracts, it's the first time that the idea of primary prevention has been recognised, and if that's built on, then the incentivisation that you're talking about can be built into that, and hopefully then, without a huge financial input, as you say, what the interventions we're potentially talking about are scalable at at relatively limited cost. So there's hope on the horizon, but we still have a very challenging context to work in, which I'm sure you know all about.
Sorry, Conor Lennon from UCC. So less of a question really, and probably more of a general kind of comment and a call to arms about this kind of software development aspect of it. So maybe Chris, we can ask to hear your response. A lot of the work we've seen in the past few days, and just knowing work in this field more generally, you seem to see a lot of things being built from scratch. So like projects get funded, tools are built, and a lot of the money and a lot of time and effort goes into designing the app from the software development perspective. So I was kind of I think somebody always says this at any technology conference, but like just the importance of releasing things open source when you finish the project, so that the next person can start where you finished rather than starting from scratch again. Because it seems like a huge waste of time just building all these apps from scratch when they share a lot of the same kind of components. So that's all I want to say. Maybe so, Chris.
Yeah, I mean, I think that, if you can hear me, I think that's an interesting point, and certainly we've suffered a lot from that over the years, where we've started again and probably reinvented the wheel a little bit. The one thing I would say is, in our software development, we've tried at times to be quite generic with what we've produced, looking ahead to think that we could reuse it, and it hasn't always been possible, because there are slight changes and slight differences that we need to have on a case-by-case or project-by-project basis. So I think the general idea that you make is right. In practice, I'm not too sure how far we could go towards achieving that. Open source and sharing the software, yeah, I mean, as a researcher, I'm being financed by public funds. Yeah, I'd be all for that. So
it's amazing how rare it happens though.
Yeah.
In a useful way that's documented and you can actually take it and use it.
Yeah.
Could I just comment that there are several toolkits out there? For example, Lucy Yardley at Southampton has led on about £2 million of Research Council funding to set up something which was called Life Guide, which was a web-based behaviour change development and delivery toolkit, but it also included tools to allow you to do studies, pilot and randomised trials on the tools that you developed. It's quite complex. There's a lot of online tutorial material. There are actually face-to-face workshops. I think there's even a conference every year on Life Guide, and there's now something called UBehave, UBHAVE, UBehave, which is moving that towards a mobile platform. Have I got that right? I'm just looking at, so there are some, at least one platform there which is moving into mobile as well. So Lucy Yardley at Southampton, Life Guide project.
Question here.
Hi, Paul Fallon from On the Road Again. We developed a program a few years ago about the benefits of physical exercise. It's a tailored program and it's done in a social setting, so everything that you guys are saying here today totally resonates with me. But Liam, as you were showing earlier on, the slides about exercise, so we all know exercise is very good for you. But the thing, I think you were calling app madness as well, with all these great apps that are out there. One of the things that we find very frustrating is trying to get people motivated to actually do the exercise and buy into it. So even if we have all the great apps out there, how do we actually get people to buy into them? Like you mentioned personality types and so on and so forth as well. And I think from the social media angle, there's probably something there that can be built on as well, but just get your thoughts on that as to the next step. You know, we developed the apps, but what's the next step as to actually get people to use them?
It's a $1 million question. No, I think patient engagement is huge and probably our biggest challenge right now. I do think there's something to be said about the social aspect, not only because I studied social media stuff, but if you think about it, back to the average Facebook user spending 40 minutes a day on it, like that's pretty stunning engagement. But the average user of MyFitnessPal, we're lucky if we could get 4 days out of it, let alone 40 minutes a day for years. So I think there's something to the social piece. I also think that it needs to be, another idea is that bringing in a healthcare provider. It was back to the question about referral. I wonder if people would use apps more if it was recommended by their physician as opposed to just something they picked up. And then supervised by their physician. So not just like, hey, take this, try it out, knock yourself out, but where there's a follow-up and a supervision process, where the provider can see the data and interact with it and use it as part of their counseling. In my lab, we're working on an app that does that, where the counselor who's working with the person on weight loss can actually see visuals of data and get suggestions for goals based on that data of what the patient might do next, so that they can sort of quickly get an idea of what's going on with that patient. It guides their counseling so that they can do it briefly and meaningfully, and maybe that would pull people into using the app a little bit more rather than having them kind of go off and be independent with it. So something needs to bring them back to it. We're doing a lot of focus groups around this too when we work on apps and say, what would bring you back to this? And it's always interesting to hear what patients say. But I think that's like the $1 million question if you are developing an app, is find out what patients' thoughts are about this. What would bring you back to this every single day? Or do you think you would stop using it after a while? Curious what other people's experiences have been with that.
Yeah, I mean, I would agree. I think it relies very much on the context within which the app is deployed. So we find from our studies, if we have a proactive caregiver involved in the process for example, you work with people with dementia, the amount of time that it's used and the engagement is much better than if a person is on their own, or if the caregiver isn't fully supportive or fully engaged in the process. So I agree with it could be from a clinical or a healthcare provider perspective, or it could be through support network from informal or family members.
I want to make partly a comment and partly a question, and it kind of follows on from the last question, which is about how we conceptualise things as to be relevant to behavioural science, because this area requires behavioural science, biomedical science, technological skills, a whole gamut of stuff. And I have a sense that behavioural science sometimes doesn't contribute as well as it should, partly because I think it's not well enough developed, but partly because we don't consistently use the same vocabulary about behavioural science. So I think the question that was just asked there was about the behaviour engaging in the app. But if we don't call it a behaviour, we don't draw behavioural science to that task. And in all of the work that's being done, there's usually two behaviours involved in any healthcare delivery. One is engaging the person in the healthcare, including the mHealth app, and then the behaviour change that the app or the healthcare procedures attempting to do. And I think we just have a fundamental problem, which is either we don't have enough behavioural science, or we don't have a common enough vocabulary to know when we're talking about behavioural science.
I'll add one more criticism to behavioral science, as a behavioral scientist.
Well, I was criticizing people who wouldn't use behavioural science.
Right. I think we're very bad at marketing our science. We're not out there in the right circles. I'm always fascinated when I go on the website of an app or some digital health innovation company, and I look at their board of advisors, and you're hard-pressed to find a behavioral scientist so many times, and I wonder, why are we not interacting and networking with these people and making our science, more aware of our science? And this is one thing that got me very much more into social media, because technology people tend to be social media users, and they're out there and interacting and networking with each other, and I don't know that we're in the right circles to get ourselves out there and to advertise what we do. But I think your point about how we talk about behavioral science is important as well. Our terms, and people probably don't know what we're talking about, and we're using different terms. And
we disagree with each other.
Right.
Because people say we eat very young.
Right,
As we're nearing the end of time, we have just one more question.
Can I just say before the question, the psychology discipline here are very effective at getting out and infecting the rest of us.
Actually, I will say that the Europeans and the Canadians do this so much better than the Americans, I've noticed. So there are no Americans there, if I can say that.
Just wanted to ask the panel about financial incentives and also tying it into payer models. So when you look at other industries, it's only when people, myself and Lee were talking about this over lunch, it's only when people are financially incentivized sometimes you see the behaviour change. So we see it in this country with recycling, God forbid to mention water charges, but for the month when we thought we were paying for water, you know, the consumption dropped. So what about in health in the same way that the young drivers for car insurance, can you see the financial incentives working to drive behaviour change?
Yes, for some things, for some people, some of the time. And there's been a lot of work on, for example, performance-related pay. And that apparently works up to about 10 or 15% of your salary being contingent on performance. Above that, it causes people to leave the profession or the organisation, and a general air of depression sets in, particularly where people can't actually realistic. So, for example, paying head teachers for the performance of their pupils may work on a small scale, but ultimately there's too indirect a causal chain between becoming a head teacher and improving the quality of educational results, and particularly in deprived areas. So I think the answer has to be it depends. It's very context bound. But it certainly works for some behaviours amongst primary care practitioners, and there's been a big programme of quality and outcome framework programme across the UK has led to quite a shift in focus of primary care consultations. Unfortunately, of course, what happens is that then reimbursed activities drop away. So, for example, management of some mental health conditions has got worse because those haven't been incentivised. Why haven't they been incentivised? Because they're more difficult to define, to give payment on. So it's a bit like the drunk man looking for his keys under the lamppost, because that's where it's easy to see them, rather than where he actually lost them. You can incentivise certain things, you can't really incentivise because you can't really define and measure other behaviours.
So that's why I didn't find my keys.
Okay,
thank you very much. That brings to a close this portion of our meeting. I'm going to ask you to stay put there for a moment, panel, but I'd like you to just show your appreciation for our panel of experts.